So nephritis, this is what we're all really here to talk about tonight. We'll have a lot of discussion about the different aspects of nephritis and kidney disease. And nephritis, in a word, anytime you see itis in a medical talk, means inflammation. And NEF, neph, is referring to the kidney. So just by definition, the word nephritis means inflammation of the kidney. So because people with lupus, like I said from the beginning, can have any and all or some or parts of their organs affected, we know that it can cause inflammation of the kidney. And patients who may be in need of having a kidney biopsy in order to find out if they're actually having lupus nephritis are people who will have blood or protein in their urine. They may have abnormal cells that come up on a urinalysis. They may have renal dysfunction, which is exhibited by abnormal blood tests. They may also have rising levels of the double-stranded DNA antibody, which you may have heard about as one of the antibodies or proteins in the blood that is responsible for causing lupus and for causing lupus activity and damage to organs, in particular the kidney. Complement, these are proteins in the blood that tend to decrease when people have active lupus. So these are all things that should be being checked when you're seen by your physician. So if the levels of these numbers change, then that may be an indication that you might need a kidney biopsy or maybe developing nephritis. Lupus nephritis, by definition, is persistent protein in the urine greater than 0.5 grams per day or cellular CAS. And this is a microscopic finding, but basically any abnormal presence of cells in your urine shouldn't be there. And that's an indication that you may be developing kidney disease. There's multiple different types of disease of the kidney in lupus. And I know Dr. Ansari is going to go into much more detail about this classification, but just to really illustrate the basics, we have 7 main categories, and 1 is normal, 2, basically all of these terms, they're microscopic terms for the way that the kidney looks under a biopsy. And class 4, this diffuse proliferative glomerulonephritis, is really the class of lupus nephritis that we consider the most dangerous and can be the most rapidly progressive to end-stage renal disease. The word diffuse means that it really is affecting every part of the tissue that has come up on the biopsy. So when we take the kidney biopsy, every aspect of the kidney that's looked at under the microscope has a lot of inflammation and a lot of disease. So that's why that's called diffuse. And this advanced sclerosing glomerulonephritis, the word sclerosing is really hardening and fibrosis. And class 6 here really is patients who have already progressed to the point where their kidneys have a lot of scar tissue. So that's another one that's not only difficult to treat, but can lead to end-stage renal disease. Another classification system, or another way that we further characterize lupus nephritis or kidney disease of the lupus, is based on the biopsy, how much what we call activity versus chronicity. And those are 2 words that we use to describe when we say activity. That is supposed to indicate how much inflammation, how many cells, how much is going on right at the moment, versus the chronicity score, which is to show how much scarring or how much time really potentially has passed that there has been nephritis of the kidney or inflammation going on. Patients who, upon biopsy, have a lot of activity and little chronicity probably are the ones that will respond the best to these immune suppressive medications, because it's indicative that their disease hasn't already caused a lot of scarring and already progressed very far. And the reverse is true. Patients with a lot of chronicity with little activity will probably, unfortunately, respond less. So the mainstay of treatment for lupus nephritis, as I said before, most of our treatments are nonspecific, and that's why you probably recognize these names of medications whether you have lupus nephritis or not. Cellcept, Imuran, Cytoxan, steroids. These are things that we use for a lot of different aspects of lupus itself, and depending on the patient, depending on the biopsy results, and also depending on various reasons why some medications might be contraindicated, that's sort of how we're tailoring our decisions now about treatment of lupus nephritis. Cyclophosphamide or Cytoxan, which is chemotherapy, and it's IV, usually used for lupus, was for many years the main drug of choice. This was the standard NIH protocol from the 1970s. Every patient with lupus nephritis who had at least class 3 or class 4 was put on this IV medication. But its side effects included hemorrhagic bladder conditions, bladder cancer, and also potentially could cause fertility issues. And for these reasons, investigations were pursued for drugs that wouldn't cause infertility. And Cellcept or mycophenolate and Imuran or azathioprine came out in the last, I would say, 5 to 10 years as basically equally effective, but didn't cause as many side effects and didn't cause fertility issues. However, when we find patients with lupus nephritis who also are suffering from multiple other organ involvements, especially if it's heart or lung and their kidneys are involved and they're very sick, then those are the times when we would still use this chemotherapy or strong immune suppressive medication despite the risks, because it would be more effective and it's more rapidly effective as well. Just to go back a little bit, generally speaking, as far as the treatment of SLE, you can put it into 2 different categories, one being active and the other being preventive treatment. And I'll just briefly go through the prevention real quick. So I mentioned photosensitivity earlier. For that reason, sunscreen, it says here at least SPF 30. I always recommend SPF 70 to my patients. Calcium, vitamin D, folate supplements. This is obviously to hope to protect you from bone loss or osteoporosis from the steroids, and vaccinations are important. Active treatment can include steroids, whether topical for rashes, NSAIDs or non-steroidal anti-inflammatory medications for joint pain, antimalarials or Plaquenil, hydroxychloroquine. This is something that I'm sure you're familiar with. Steroid medication, and of course the cytotoxic or biologics. As you know, medications can be very complicated. They can be very difficult to use, very difficult to comply with at various times. And one of the reasons is because of the side effects that people experience. You may note weight gain, hair loss, new hair growth in unwanted places, damage to the bones, high blood pressure, high cholesterol, and a reduction of your immune system response to infection. And these are all side effects from steroids. So for follow-up visits, how often you need to see your physician really depends on lupus activity, severity, on your response to treatment, the types of treatment, and also how often you need to be monitored for side effects from your medications. At routine visits, and we do this for all of our patients, blood and urine needs to be checked, even in patients who were previously normal. We also, even in patients who have strictly cutaneous lupus, for example, discoid lupus patients who don't have any current systemic issues, we routinely check their blood and urine, I would say 2 to 3 times a year, just to make sure that there's nothing brewing that, because they can eventually develop systemic lupus. So a little bit more detail about kidney disease. As I said before, it's one of the greatest sources of morbidity and mortality. It develops in just under 2/3 of patients with lupus. About 5 to 22% of patients with lupus nephritis may progress to end-stage renal disease requiring dialysis or transplant. And this is a fairly significant number, and for these reasons why we're strongly committed to treating lupus nephritis. In a group of patients at Johns Hopkins Medical Center, 15% of lupus patients developed end-stage renal disease after 10 years of disease. And 10% of patients in the NIH and 20% of patients at NYU Hospital for Joint Diseases experienced progression to end-stage renal disease despite treatment with IV Cytoxan. So these are patients who went on to renal failure even though they were actively treated with this high level of chemotherapy. In 1995, the U.S. Renal Data Systems came out with an annual report that estimated about 1.4% of end-stage renal disease was accounted for by lupus patients. And it's usually defined as what we call a GFR, or glomerular filtration rate, of less than 10% normal. Other indications of unfavorable outcomes in lupus nephritis or potential for progression to end-stage renal disease are a doubling of the serum creatinine or persistent high levels of protein in the urine despite treatment. Which are the patients that have kidney disease that should be most worried, or that we should be most worried about, that are going to progress to end-stage renal disease, and how can we target those patients best? As I mentioned to you before, one of the ways of assessing the kidney on a biopsy is by describing the level of activity versus the level of chronicity. And at the time of biopsy, patients who have higher chronicity scores tend to have poorer outcomes or lack of response to immunosuppression. And that's because that chronicity is indicative of just the word chronic, but it's been there for a long time, or at least the way the kidney looks is that it's been being damaged for a while. Also, patients with severe and active chronic histological changes are at increased risk for renal insufficiency and failure. Other risk factors for progression to end-stage renal disease include being Black, males, the presence of APL antibody, and these are antiphospholipid antibodies. Those are the antibodies or the proteins in the blood that may make you at higher risk of a blood clot. A patient who has an increased creatinine than at the time of diagnosis, having anemia, having frequent flares or frequent periods of activity of the nephritis, high blood pressure, or extensive prolonged protein in the urine. So what are the options if a patient does progress to end-stage renal disease? Renal replacement therapy, including hemodialysis, peritoneal dialysis, or kidney transplant. My colleague can probably speak more about this because she's a dialysis doctor, but when is the time, or when is the time that you have to start thinking about putting patients in dialysis, or what are the circumstances that may indicate it's time? Knowing when to change the plan. So although lupus itself can cause a rapid progression of nephritis, that's RPGN, it can progress over several years. And basically, all these years of treatment can lead to various problems and various complications. So it's up to the physician and the patient to decide when the treatments are just not working out and when the kidney is not responding, which point not to quit, but to sort of change gears and to move on to dialysis or to another plan. And one of the reasons, or some of the reasons, may include AVN, which is avascular necrosis. That's basically death of bone, and you can experience that in your hips, in your shoulders, and the elbows, and this can be a result of chronic kidney disease and of treatment with prednisone. Opportunistic infections, these are infections that result from being on chronic immune suppressive medications. Risk of malignancy, as I said, that cyclophosphamide is chemotherapy. That drug and also some of the other cytotoxic drugs do have a small risk of malignancy. Obesity, an increased susceptibility to CAD, which is coronary artery disease. A kidney biopsy demonstrating the sclerosis and high chronicity may signal end-stage renal disease, as I mentioned. Patients who are just not getting better, who every time they come back, you keep hoping and you want them to have no protein and no blood in their urine, but every time you check the urinalysis, there's still all those abnormal findings. And that may be a suggestion that it's time to change medication. You change medication, hope and pray and wait and watch, and then it still doesn't get better. So these may be the patients that have to move on to dialysis. How is it decided whether dialysis or transplant? In lupus patients with multiple other medical problems, or if they also have what's called the APL antibody syndrome or antiphospholipid antibody syndrome, which, as I said, is a disorder that makes you at risk of blood clots, dialysis or peritoneal dialysis may be the most appropriate type of renal replacement as opposed to a transplant. The survival of lupus patients on dialysis approaches about 90% at 5 years. There's really no substantial difference observed between hemodialysis and peritoneal dialysis, though there is an increased risk of peritonitis, which is an infection of the fluid in the abdomen when using peritoneal dialysis. Early studies showed that the greatest mortality is in the first 3 months of dialysis, usually the result of infections. And then thereafter, much like the disease itself, infections and cardiovascular disease are the largest threats. The question always remains, once dialysis is initiated, A, is the rest of your lupus going to remain active? And B, should patients still stay on all of these immune suppressive medications? If we're switching gears and putting patients on dialysis, do they still really need to be treated with immune suppressive medication? You have to really weigh the benefits. You have to really assess the other aspects of the lupus. If you still have a lot of problems with your blood cells or inflammation of the lungs or heart, clearly you still need to remain on immune suppressive medications. So kidney transplant. Some patients with living related donors are transplanted successfully very quickly and don't usually need to be on dialysis, if not for more than 3 months at a time. But there obviously is a very long waiting list, and that's why several patients become dialysis patients for quite some time. Some of the issues for lupus patients who are transplanted include many of the same issues that patients who are transplanted that don't have lupus. But most of the studies found the overall survival rates at 5 and 10 years are similar in lupus patients and non-lupus patients. So it's really the same risks-benefit analysis. Ward did a research and looked at the U.S. renal data system to compare lupus versus non-lupus transplant recipients, looking at age, sex of the donor, race, all of these variables, and basically found that the response rates and the success rates were the same across the board, whether you had lupus or whether you needed a new kidney for another condition. So one of the complicating variables of dialysis is atherosclerosis. You may have accelerated atherosclerosis in transplant patients, regardless of what your kidney problem was. You may require aggressive treatment of hypertension and high cholesterol because of the transplant. And reducing cardiovascular risk can only be accomplished by reducing both of these risk factors at the same time and making sure that your lipids are under control. Just to conclude, as I mentioned, as far as who's going to progress to kidney failure or end-stage renal disease who has lupus, sometimes the biopsy itself can be used to prognosticate, meaning the patients who have that diffuse proliferative are those ones that we have to be most vigilant about, and patients who already have sclerosis and a lot of chronicity on their early biopsies are the ones who are at most risk of end-stage renal disease. And I mentioned to you the list of known risk factors, including African American, being male, having high blood pressure. These are all variables that need to go into play when we're taking care of lupus patients who have kidney disease. The majority of studies support the tendency towards reduced clinical and serological activity, meaning that the rest of your lupus is expected to potentially become quiet once you're on dialysis, but that's not definite, and you still may need to be treated. But it's important to remember that the outcomes of lupus patients on dialysis and also in transplant are really not dissimilar from the other patients with kidney disease. So they're both definitely viable options for people who have progressed, unfortunately, to end-stage renal disease. Thank you.